Hello, everyone. Welcome to Tuesday Night Rheumatology. This session is going to be on ILD, just like all the Tuesday Night Rheumatologies in the month of September, where we have a campaign called Room to Breathe, all about ILD. In these Tuesday Night Rheumatology sessions, we focus on a specific issue. Last week, we talked about treatment and future treatment. Tonight, we're going to be talking about controversies in ILD. I want to remind you, again, Tuesday night, 7 p.m., all throughout September. Next week, we're going to do Journal Club, two very important journal articles that have defined the treatment paradigm in ILD. And then in our last week, we're going to have a session devoted to diagnosis, screening, and monitoring. Tonight, our session on controversies in ILD, I'm joined by the experts, and I'm going to ask them to introduce themselves. I'm Jack Cush in Dallas, Texas. Elena?
Hello, everyone. My name is Elena Joerns. I'm a rheumatologist at Mayo Clinic in Rochester, Minnesota.
Janet?
Janet Pope, welcome to At Room Now. I'm a rheumatologist in London, Ontario, Canada.
And Dr. Sparks?
Hey everyone, my name is Jeff Sparks. I'm a rheumatologist at Brigham and Women's Hospital in Boston, Massachusetts, and very excited to be part of this campaign for the entire month of September.
I want to thank each of, and these three folks have been part of the advisory committee that has been working for a few months on generating content, speakers, topics, and whatnot. And so I can't thank you guys enough for your expertise. I've learned tons in a very short period of time, and we have lots and lots of content. So far, what we've learned, and I'm going to use RA-ILD as an example. And these are things that we covered in part last week and has currently been covered on the website in content that we've already generated. But I like the 3S rule. I learned that from Jeff about 2 years ago. That is seropositivity, smoking, and sex being male with UIP it really increases the risk of having UIP significantly. So the 3S rule is really important. These patients with ILD are at much higher risk of serious infections with at least a threefold higher risk and a 3 to 5-fold higher risk of mortality. So this is bad, bad news. You can know who's really at risk by looking at what happens to their FVCs in the first 6 months. Rapid progression of that FVC leads to significantly worse outcomes, and you can define it with a few serial tests as far as your FVCs. The question is going to be how to treat them, and does our treatment as rheumatologists with DMARDs change what happens with ILD? There's a little bit of data on that, and that kind of suggests that that might be so, but we need to know about the more specific therapies for ILD, when to add immunosuppressants, when to add anti-fibrotics. And the good news is we have 2023 and 2020 from the ACR and 2025 from EULAR recommendations on the management of ILD. Any comments from our panel on just this information that's already been laid out? Jeff?
Well, I'll just emphasize, we think RA is doing very well, and it is. We have a lot more treatment options. The joints overall are less likely to erode. This is the outlier. This is one of the few outcomes across all of rheumatoid arthritis that it's not getting better. The prevalence seems to be increasing. We're still having excess mortality risk. These patients still get infected. So from a rheumatoid arthritis standpoint, these are the patients that you worry about and that our current therapies have not put a big dent in. And obviously, we need a lot better data. We need more trials. And it's great that there are some recommendations from both organizations, but nearly all of them are conditional, as you've highlighted. And that's really just because we don't have the trials that needed. And this is our most common rheumatic disease. So to me, it's a call to arms that we need better data.
Yeah, Janet and Elena, you've been working in this for a number of years now, noting how important this is and that research is needed. Any comment?
I'll make a brief one. I think that those listening who were on last week heard excellent description of how the recommendations got to what they're like now. And I think sometimes a conditional recommendation is because, as Jeff said, the data are missing, but that we have enough I'll call it real world data and subsets of studies that we have enough data to say that interstitial lung disease is probably going to do a lot better when we treat the RA disease effectively. But that I think, it's my opinion now, that some drugs are more lung friendly than others. And that's pretty important to note. And I'm not going to go through my list, but I just think some have more data than others. And we're going to get into controversies thereafter.
Right. Elena.
Yeah, I will add that it is exciting that we're getting these guidelines for ILD. I think it is improving our understanding how common it is. It's going to improve it even more once some of these conditional recommendations come into action in the clinics, where more people with Joerns will get screened, more people with myositis will get screened. Hopefully, most of them are getting screened already. So I think we will be getting more data, and I'm excited to be part of it.
Last week we talked about as Janet alluded to, we talked a lot about the ACR and EULAR guidelines and how they are, number one, that rheumatologists are aware of them and that they are aware of what it means to screening, how to screen, who to screen, and the big thing we heard from Shane Shapira from the University of Toronto last week that he really liked about the guidelines, especially the EULAR guidelines, is that everybody should get screened pretty much. And an RA that has risk factors, but pretty much everyone should be screened, and that an HRCT is the way to go. And I think that's a significant shift in how we consider this. So to prepare and to move the discussion along for this particular session on controversies, we did a survey of rheumatologists. A one-time email went out on Monday morning when less than 24 hours. 235 of you responded, 85% being rheumatologists, 5% being advanced practice providers. And we asked a number of questions, I think 12 questions all together, where we talk about some of the acronyms and the terminology. We'll refer to that, specifically about IPAF, what it is, and how autoimmunity plays in. We get into the methotrexate controversy that rheumatologists and pulmonologists love to do spar about. And then specifically management looking at UIP as an example. And we'll discuss some other smaller issues like cancer risk, whether our patients can get transplant, what's the role of AI in the future. So first question, when we ask rheumatologists, how comfortable are you at distinguishing and diagnosing the different types of ILD that are related to connective tissue disease, systemic autoimmune rheumatic disease, and these other terms, IPAF, PPF, PF-ILD. It's an AEIOU kind of world in pulmonary rheumatology. And I like this answer because I think this reflects my own thinking. 42%, 43% not confident, 45% somewhat confident. This is very sobering. Only 7% of us really have this nailed. I think the 7% are the panelists I'm going to have on these TNRs, right? They're the ones that we're looking to. And only 5% of you are confused by the acronyms. Let's go over those first. Elena, can you explain those? CTD we know. SARD, IPAF, can you tell us what those are?
Yeah, so CTD is going out of fashion. The new preferred term is SARD, systemic autoimmune rheumatic disease. This was a term that was proposed by the ACR CHES guidelines on SARD ILDs that recently came out. IPAF is interstitial pneumonia with autoimmune features, which is, well, I'm sure we'll talk about more, but this is my clinical and research focus. That's the interstitial pneumonia where patients have some autoimmune features, but they don't meet any criteria for any SARD. And SARD being myositis, Joerns, RA, scleroderma. PPF is progressive pulmonary fibrosis. And that's a term that was introduced by American Thoracic Society. There was a recent guideline on it. So essentially, anybody with pulmonary fibrosis who's progressing, and there are a few definitions for that. They define it by increase in respiratory symptoms, increase in the radiographic appearance of fibrosis, decline in pulmonary function. So there are a few criteria that these patients need to satisfy. And PF-ILD is progressive fibrosing ILD, not necessarily used more commonly than PPF. I will say that, you know, somewhat confident is where I often am myself, because it can be hard to say. It can be hard to say. And a lot of the times the data is very subjective. So depending on who's looking at your CT scan, hopefully with the emergence of quantitative CTs, we can get this answered a little bit more objectively in terms of the progression of fibrosis. But I think sometimes it is hard to tell. So I'm with you there.
So that's surprising. Janet and Jeff, are you in that same boat? Are you sometimes only somewhat confident and maybe with time you get more confident? Janet?
So first of all, I understand where Elena's coming from, because I might be a little bit more confident, but the terms are not always standardized. So some trials, PPF is defined as an X% of pulmonary fibrosis on an HRCT and a worsening of FVC by a certain percent over, you know, months or even up to 2 years, or DLCO going down even further over months or a couple of years, not to be thought that it's from infection or other reasons. And so that's why I would almost be between, I'm straddling the purple and the blue, because sometimes it is difficult to note. I also think that sometimes these terms are used in order to get access to a drug with, of course, a person with ILD. But I'd probably sometimes bend the rules a bit if I had someone with IPAF that we'll talk about later who might need treatment. We got to decide what really are we going to call them to get appropriate treatment.
So Jeff, I think some of the confusion can be from the acronym. Sometimes it can be from diagrams like this about what is ILD, and it looks like it's an insane Christmas list of some sort. I'll put up a slide and ask you to sort of just give us a sort of an organizational overview of ILD and any comments you like.
Sure, I'm impressed that so many people were confident and not as many people were confused by the acronyms, and you could have put more on there, honestly. So this is one of these busy slides, and this is intimidating about ILD, and this is how a pulmonologist thinks of how to classify that. On the left side are the idiopathic pulmonary pneumonias, the most prototypic one being IPF, which basically is fibrotic, typically is idiopathic, so doesn't have a rheumatic disease, doesn't have an exposure, and those patients do very poorly. Kind of a cousin to that are nonspecific interstitial pneumonias, or NSIP. Those are typically a more inflammatory phenotype, at least on the imaging. And you can see a smattering of different other subtypes that are less common. The autoimmune ILDs, and this will be a controversy we probably go into later, the pulmonologists prefer the term CTD ILDs. We are seeming to prefer the term SARD ILDs. And then Elena Joerns here is really studying IPAF, which is ILD. It's bona fide ILD, and then it has a few features of autoimmune diseases, but not enough to be either diagnosable or classifiable if you're thinking about either clinical or research. Obviously, we're very comfortable about diagnosing the underlying rheumatic disease that are listed there. Certainly, some people have overlap syndrome, which can make things difficult. Probably the most common one, at least by prevalence, would be systemic sclerosis ILD. MCTD ILD is pretty common as well, myositis. From a numbers standpoint, while RILD is relatively less common, maybe about 10% of patients, there are the most number of RA patients. So from an absolute standpoint, there are a lot of patients with RA-ILD. And certainly a lot of people are unclassifiable. Then you start thinking about sarcoidosis, which is rheumatology adjacent, but kind of has its own natural history. And then really thinking about occupational exposures. Certainly smoking is the one that comes out, but obviously pulmonologists are very good about figuring out who has, birds in their house, who's spelunking, and, silica exposures from occupational exposures. So this is intimidating, and often people don't fit neatly into one of these boxes, which is challenging. And things that aren't on this list, of course, smoking injury, infection injury, drug injury, radiation, and people, GERD. So these are really complicated patients. Obviously thinking about malignancy and atypical infections as well in our patients that are immune suppressed.
All right, I think they're off to a fabulous start with you guys really giving good perspective and organization to this. So here are, and I want to encourage our audience that if you have questions, please put them in the Q&A box, and I'll be addressing those as we go along. Let me see. We don't have any in there yet, I don't think. Let me look. Q&As. So it's open, and you can drop in your questions, and we'll ask real time, and we'll say your name and where you're from, and send you a check, maybe, probably not. So here's the first set of questions that deal with IPAF, interstitial pneumonia with autoimmune features, and I like that you distinguished it from SARS, which has more certain autoimmune, an autoimmune base. So the question is, should IPAF be regarded as an autoimmune ILD? A third of you said that it depends on the autoantibody profile. A third said, I don't know. 16% said it depends on the chest CT, and 12%, yeah, sure, why not? Elena, what do you think of these results?
Seems like a real world example, and I think everybody is right. Everybody is right here, because in some cases, IPAF can be autoimmune, and sometimes it really depends on what their autoantibodies are, and I'll go into it a little bit more. IPAF really is probably a mix of things. So IPAF it's actually a research designation, even though we all love to use it as a diagnostic designation. And we love to say, okay, this is IPAF, autoimmune, let's give them immunosuppression. It is technically not entirely correct. And what we saw with IPAF classification criteria that came out in 2015, it actually alerted people that there is this disease entity that we don't understand enough about. And really, those classification criteria were designed to really encourage trials of these patients. We didn't see it as much, but we are seeing it some. There are definitely a lot more studies on IPAF now that came out since the introduction of those criteria, and we can understand a little bit more what kind of patients have been studied. And we're seeing that, for example, IPAF with myocytic-specific antibodies, so like anti-synthetase antibodies, MY2 antibody, SRP, those tend to behave the same as myositis ILD, so ILD with a SARD myositis. So those patients have a very similar response to immunosuppression and a very similar survival prognosis as well. And what's really interesting, it actually doesn't seem to matter whether they have this UIP, the usual interstitial pneumonia pattern of damage, which is thought to be really kind of fibrotic and non-autoimmune pattern, or if they have an SIP. So they seem to respond to immunosuppression regardless of the underlying lesion. And I'm sure Jeff will talk about it a little bit more, but in our UIP, we often attempt immunosuppression as well, because we know that they have an autoimmune disease. So depending on the autoantibodies, some IPAF really should be regarded as an autoimmune disease. And there is a movement now in the myositis world to really call IPAF with myositis-specific antibodies just myositis ILD. So if you all are familiar with the criteria within IPAF, so in order to meet classification criteria in IPAF, the patient needs to meet 2 out of 3 domains, and that's serologic domain, clinical domain, and morphologic domain. And within the serologic domain, there's a list of all of those autoantibodies, and there's been a call to remove the myositis-specific antibodies from there. And I think it is an appropriate call, and I think we need to revise the IPAF criteria based on that. And I think the more we study, the more we revise the IPAF criteria, I think we're going to become more confident about what we are dealing with. Now,
so I like that those are in flux, but where do you get, how does a rheumatologist handle this fact? A patient who has IPF, idiopathic pulmonary fibrosis, there's going to be a lot of action in the lungs and a lot of stimulation of immune cells in the lungs and alveolar macrophages. And I'm not surprised that they make autoantibodies that may not be pathogenic. So how do you make that distinguish? You know, someone who just has an epiphenomenal ANA. I mean, you had I tweeted the results of your IPAF study and comorbidities, which I thought was great. 201 patients and 80% had an ANA. I think 50% had a rheumatoid factor, 14% had CCP. And you showed that these people with IPAF met the criteria, as you mentioned, that they had a much higher incidence of comorbidity and death, as you would expect if it was a real disease and not just epiphenomenal antibodies. But there must be this subset of people who have antibodies that aren't pathogenic. So how do we distinguish?
Yeah, and that's a really good question. You know, we actually did a study. I'm hoping to publish it soon. It was presented at EULAR a couple years ago, where we looked at lung transplant recipients. So we looked at patients who received lung transplants, and of course, then we have access to their biopsies, and we're able to review those biopsies. So a lot of those patients that were regarded as IPF prior to transplant actually had positive serologies, and then on explant they had inflammation, more than just mild inflammation. They had some sort of NSIP pattern. So these autoantibodies probably do reflect something that's going on within the lungs. Now, we're not doing a lot of biopsies on these people because a lot of times it doesn't necessarily change management. A lot of times they have other comorbidities and we want to try other things. Perhaps we should be thinking about doing more biopsies on them. But, you know, even if you do a biopsy, you might not get the best sample and it might still not be diagnostic. A lot of those people who had transplants, they had biopsies before that showed UIP, but then you examine their explanted lung and it's actually more like NSIP, and they actually technically meet IPAF criteria.
Okay, so before we go on to the next question, I'll ask for a few comments, short comments from Janet and Jeff. Janet?
Right. So quick one. I think, Elena, I think your way of thinking about this is quite interesting. However, it's the difference, as you're saying, in a way, I'm going to sort of summarize it, between lumping and splitting. If I have a patient with NSIP and they're short of breath and they have Raynaud's, a strongly positive whatever antibody, I don't see much else going on. I can't make a diagnosis, even though it's a centromere or a nucleolar, a kind of interesting antibody, or a Smith or something, if we're looking at the ENA. I think really in the end, you're going to say, well, let's just treat. Let's just say, I can't really say your IPAF for getting a treatment pathway, but you most align with a lupus patient, or which isn't in the guidelines on the ACR, or you most align with kind of your scleroderma-like. And I think, interesting, Jack, there is a question in the audience that is exactly this kind of thing. Was the person IPAF because they were an IPF pattern, established pulmonary fibrosis, had CCP positive, and then eventually got their RA? So if these folks lived long enough, is it just the first manifestation of what they were going to get? And some of them will never get there, the same way we'll see Vitos that isn't yet scleroderma kind of thing. So that for those reasons, I really think that people are, you know, there should be controversies in how we vote, the 1/3, 1/3, and 1/3 voting other.
Jeff?
You know, this, I think, is a really important area because these patients exist and they're really tough. And, you know, this is, I think, an illustration about when a research definition is applied to the clinic, and it's just frustrating. You know, these people have a real disease. They have ILD. Typically, the ILD is quite severe, honestly. And the pulmonologists see them and they find, you know, antibodies or some, you know, Raynaud's, et cetera. and they send them to the rheumatologist, and we say they don't have a rheumatic disease, and it does tend towards frustration from both providers. They kind of fall through the cracks. The pulmonologists don't want to treat, the rheumatologists don't want to treat. Next thing you know, 6 months has gone by. So it's a, really, we really need to make progress on these patients, and, honing the research definition and knowing how to apply it to the clinic, because at the moment, like I said, they're falling through the cracks.
So while it sounds like it's a nicely defined entity that needs a lot of research, I'm going to draw the analogy and say that IPAF is to, a more certain SARD, just like undifferentiated connective tissue disease is to what will evolve into scleroderma, myositis, RA, lupus, etc. And I think that makes sense because it's really a parallel. It's just a different organ system.
Yeah.
But it should nonetheless lead to a heightened concern. And I like Elena's point that maybe you can't just blow off the ANA or the rheumatoid factor in these people like you would in an ANA positive consult. It may mean more in the setting of lung fibrosis. So let's go to the next question. When would you use immunosuppressives in someone with IPAF? Janet, I want you to tackle this. The audience answered a third saying, well, I would use it to control what I think is autoimmune disease. A third said they would ask pulmonary what to do. 15% would say with specific autoantibodies, and 15%, I think, because it was a leftover answer with a non-UIP pattern. I guess there's this thing. I only gave them a few choices here. So Janet, what do you think of these answers?
Well, first of all, I'd be very interested if it's the same people voting those same colors each time, just because there might be really different schools of thought here. So first, I'll agree with Jeff that if we say this isn't, I cannot diagnose RA. If somebody's CCP is 200 and they have a UIP pattern and they have to have something else, they might just have arthralgias. We say they don't have inflammatory arthritis. They have to have something from a category of symptoms and antibodies, and then the morphology, which to us we'll just say is the CT pattern. So you can understand that if we say, well, you hit the nail on the head as well, Jack, that if you have an autoimmune-ish disease and it looks like you're heading towards a scleroderma pattern or a scleroderma phenotype, even though, so they have dysphagia, we'll say, a centromere ANA and Raynaud's late onset, couple dilated capillaries, but not enough to make no sclerodactyly, not enough to make an actual diagnosis. And they have IPF kind of pattern, like a UIP or even an NSIP. I might say, you know what, they're worsening, let's treat them. You don't have scleroderma, but I'm going to go down the pathway. So that is what I think a third are kind of saying. Another third, you go back and forth with rest, and for the pulmonologists lean on us for this. They want us to we might be the prescribers, they might be the prescribers. They're very confident and comfortable if it's progressing pulmonary fibrosis. But I think with the NSIP, IPAF kind of individual, they're leaning on us to say, like, is this a rituximab patient? Or is this are you going to give methotrexate or MMF? So I think that the people that are working with their pulmonologist, we just answer the question they ask. Do they have a CTD or do they have a SARD? And we go, nope. They need more than that from us just to know. Specific autoantibodies, I think it's not just what the antibodies are, but the titer. We're all going to pay a lot more attention to an ANA of 1/1200 as opposed to 1/80. We're going to pay more attention if you have some very specific autoantibodies. And as Elena said, they're going to probably get rid of those myositis that were in PAV, well, myositis-like patients, and just say, you know what, these people have an entity that is apt to progress, just treat them. So that's removing those people too. So various antibody guidance. And then with a non-UIP, because they might be answering that, some of the people listening that answered this, and thank you for doing the survey, they might be thinking, well, in other words, no matter what the diagnosis, if it's UIP, maybe my pulmonology colleague takes the lead. And if it's not UIP, maybe the rheumatologist takes the lead. So that answer there, the 15%, is really tough to know the thinking behind the answer. Again, it does show that we have a lot of ways to go, that this is controversial what to do.
Okay, so I want to underscore the point that Janet made, which is the pulmonologists are looking for us to help them. So we, and this is where co-management and discussion really is gigantically important. Our next questions in this area is, how would you treat a SARD with UIP, and how would you treat an RA-ILD with a UIP? So on the left, 30% want to refer. 25% will use immunosuppression. 22 will say it depends on the SARD, which RA, scleroderma, whatever, and 21% are saying fibrotics. And then when we ask on the right, RA-ILD, 32% will use immunosuppressors, anti-fibrotics in 18%, and both immunosuppressors and anti-fibrotics in 47%. Jeff, this is something that you're really involved in. What do you think of these answers? What's the guidance here? What should we be doing when we see UIP?
You didn't have an all of the above option, I see, because I think you can make a case for many of these for sure. I'll take the one on the left first. I mean, granted, RALD is just a subset of that one. I think, just low-hanging fruit, even in patients that clearly have UIP and ILD and there's always some diagnostic challenge related to infection and GERD and cancer, et cetera. But, even in patients you're very confident with the diagnosis, I do think co-management with pulmonary is, almost always paramount, because there's going to be questions about prognosis, monitoring, how often do you get PFTs, how often do you get HRCT? So I think the refer to pulmonary is certainly part of the backbone here related to the multidisciplinary discussion. And I actually do like how the recent EULAR ERS guidelines outlined this, and that, if there is undertreated rheumatic activity, that you really should try to get the underlying disease under control. And obviously it'd be great if that was the same med that is pulmonary friendly and that we know has good data. Certainly the best data is systemic sclerosis. Oddly, the UIP pattern is not the predominant pattern in those patients. Considering, let's just take RALD now. Certainly if their joints are flaring, you want to try to get them on a DMARD that gets them into remission or at least low disease activity. And maybe this is a case where some at least moderate dose prednisone might be warranted, particularly if they're symptomatic or you think they're rapidly progressing. And there luckily are at least some options that have some data. Tocilizumab has an FDA indication for systemic sclerosis ILD, so you could make a case of using that for RA. Abatacept has some nice observational data. And rituximab probably has some of the strongest data related to treating the joints and the lungs. The question is whether you throw everything at them at once related to anti-fibrotics and anti-inflammatories, whether you do this sequentially. And I think typically I do try to go down the immunosuppression route first in RA-ILD, and if needed, add on anti-fibrotics later if they're progressing through that. But there might be some cases where you kind of go all in at the outset in someone that's rapidly progressive. And luckily that's not the commonality in RA-ILD. And also just keeping in mind that at least the currently approved anti-fibrotics are poorly tolerated. So that's another reason to think about doing this sequentially, because if they have a side effect, if they're on MMF and nintedanib, for example, and they have diarrhea, you're not exactly sure which med to blame. And to extricate both of those medications right off the bat may not be the best for them.
So where is
you can do the whole hour on this question.
I know. So where does nintedanib fit in? If you're going to use immunosuppressants first, that's fine. But is there a subset of these patients? Must they be UIP? Must they have a lot of fibrosis to be a good candidate for nintedanib?
At least in RA-ILD, the UIP pattern seems to be more responsive to both anti-fibrotics, nintedanib and pirfenidone. Systemic sclerosis is a little bit more of a wild card, given that NSIP is the predominant pattern, and these drugs do seem to work for them, at least nintedanib. But in RA-ILD, for a non-UIP pattern, I'm not sure that I would be reaching for nintedanib or pirfenidone, at least, without exhausting the other options first.
Okay.
And I think you want to see that it's progressing, because somebody, again, if like last week when there was a mentioning of screening all these people with HRCTs at the beginning, we're going to have smokers, older onset RA patients that will have some scarring bilateral from, they have emphysema and a little bit of scarring, or they have old pneumonia. So it's atypical scarring in that it's only mostly on one side or not at the bases. We're going to find a lot of things that even with honeycombing scarring or traction bronchiectasis kind of words, that they might not be progressing. So I think for us as rheumatologists to really seek help in this area is if they don't have a hugely fibrotic CT, so if it's under 20%, which is still a lot, or even under 10%, under 20%, but over 10, I'm going to get help from a pulmonologist anyway. But I think really you want to see that it's progressing, or is it stable? Because all you're going to do right now with the anti-fibrotics on the market is you will not stabilize necessarily. You certainly won't improve. On average, you slow worsening. So that's where I think, Jeff, I fully agree that even if it looks pretty fibrotic with the RA, we know that controlling the extra parenchymal disease activity is a good thing for ILD, and having it out of control is a bad thing. So that's, I think, also why we would reach for our immune suppressants in an RA patient, even if they're fairly fibrotic in their lungs.
Okay, let's get on to the next issue, which I want everyone to refrain from going a little too berserk over, and that being methotrexate and what we in rheumatology think about methotrexate. So here are the ground rules on this. I'm going to read you the 3 questions. You're going to memorize the answers. I'm going to go to a summary slide, and we can discuss that for about 6 minutes, okay? Otherwise, we can do, as Jeff said, an hour on this. And so the first question, how confident are you distinguishing between ILD due to the disease or idiopathic from methotrexate pneumonitis? And 49% say they're somewhat confident. 25% say they're confident. 23% say nah, not confident at all. And some want to wait for the pulmonologist. Next question. In an RA patient on methotrexate, they develop and then are also treated for their ILD, and you're going to make the decision about what to do. Will you continue the methotrexate? Yes, 52%. You're going to ask for pulmonary input, 26%. You're going to stop methotrexate, 19%. And no one's getting a lung biopsy. I kind of agree with that. And then I asked the same question in a different way. I think you kind of showed your same true colors. What's your position about treating patients with pre-existing lung disease? Again, 58% say it's okay to use methotrexate if it's needed. 27% are exercising caution about using methotrexate in this setting. 9%, 8% are avoiding methotrexate, and 7% are consulting. So this is a very controversial area where rheumatology and pulmonary don't often agree on what should happen. So I have this summary slide, which is meant to be instructive, that shows that this should be a non-issue, because hypersensitivity pneumonitis happens early after methotrexate is initiated. It's an acute onset. It's hypersensitivity pneumonitis. On bronchoalveolar lavage, they have lots of polys and they're steroid responsive. On the other hand, RA lung, RA-ILD, is very slow, takes years to develop. They often have extraarticular manifestations in RA damage and deformity, and they're often seropositive, and BAL shows mononuclear cells, and they're not steroid responsive. And, methotrexate related stuff goes away with steroids, and rheumatoid lung doesn't, has very poor 10-year survival. Yet I put in a number of citations which say it's a mixed bag. If you look at the meta-analyses on this, it basically says there's very little evidence to suggest methotrexate makes ILD worse. But there is evidence that says that it may be true, which is why some pulmonologists still hold true to this. So I'm going to ask my panel to each give you their opinion. I'm going to start with Elena, because she's got to deal with this over the kitchen table every night because she's married to a pulmonologist. How does that go over dinner?
Well, my husband is very much pro-rheumatology thinking. So he was an early adopter that methotrexate is totally fine.
Okay.
So it goes very well. Yeah, methotrexate hypersensitivity, I agree with you. It's very hard to distinguish in literature because there is such a mixed bag where they really just had a new diagnosis of ILD. I have had patients that I had to begrudgingly diagnose with methotrexate hypersensitivity. It was very temporally related to me starting methotrexate, and then they were saying, oh, I'm feeling short of breath and kind of coughing a little bit more. So then I stopped and they, oh my gosh, improved. So it does happen, but it does not happen in such a profound manner as what ILD is going to look like. I really like that the Spanish Society for Rheumatology actually gives guidelines on the methotrexate already in the RA-ILD. So they really don't encourage discontinuation, and really just a conversation whether they still need the methotrexate upon diagnosis. Thankfully, I don't have to deal with methotrexate too much. I don't have to argue about it too much, just because I'm seeing so much more IPAF, and most of the time I will be really targeting their lungs mostly. There is data that methotrexate helps with ILD in RA, but that's not an average patient that I'm seeing.
All right, Janet.
So just, I think, a quick clinical pearl here. To me, hypersensitivity pneumonitis with methotrexate, the differential diagnosis is an atypical infection, viral, COVID, as a, for instance, COVID or PJP or Legionella or some atypical thing, because they often have some eosinophilia because it's kind of an allergic thing, and it can fully resolve. It usually responds to stopping the drug and steroids, but most people are bronched and then covered if they suspect any infection. So I think for the listeners, it should not at all be confused, as Jack said. It should not be confused with a chronic interstitial smoldering and then worsening lung disease. And in fact, maybe our biggest mimicker of an ILD would be those MDA5 that they come into hospital and are presenting with severe lung disease, rapidly progressive, and could be lethal. And that's not all the MDA5s. That might sort of in your mind say, oh, they had inflammatory myositis and I started them on methotrexate. Now this is happening. We'd blame it more on the MDA5 than the methotrexate. But otherwise, shouldn't even be in the differential.
Okay, Jeff, any comment?
All right. I know I don't have the whole hour, so I'm going to give you some actual data. This is a study that Dan Solomon and I helped to run as a secondary analysis of the cardiovascular inflammation reduction trial, which is the largest methotrexate placebo-controlled trial ever done. 2,400 participants were randomized to methotrexate, 2,400 randomized to placebo, followed for over 2 years, and we adjudicated every case. There were 7 cases of pneumonitis out of 2,400 patients, which was 0.3%. This is really, really, really rare. And I'll say, having tracked down their charts, this was not ILD. This is what you're talking on the left: acute onset, fluffy, fevers, inflammatory, steroid responsive. The other bit of data is that our group did a meta-analysis where we looked at every DMARD to see whether there's a future risk of ILD. And we found 7 observational studies that we felt were of high quality that looked at methotrexate versus an alternative comparator. These patients had RA, and the odds of having future incident ILD was 0.49. So less than 1, meaning perhaps protective. We didn't, being cautious, we didn't say it was lowering risk, but it certainly was not increasing risk. So this is really reassuring about, this is an infrequent complication. It's a very different phenotype than ILD, and it doesn't seem to put people down the road to developing ILD in the future.
That's really encouraging. All right, I really, really appreciate the perspectives on this, because there is still a lot of talk mainly because we see a lot of ILD and we worry about methotrexate like everyone else. What is the greatest challenge for rheumatologists in dealing with ILD, SARD ILD, IPAF? Delays in diagnosis 40%, applying guideline recommendations 28%. Non-specific symptoms, I think that's a real big problem because like when do you start worrying about this? And the earliest symptoms are quite non-specific. And then referral and care issues. Anybody want to tackle any of that?
Yeah, I'll take the non-specific symptoms part related to screening, because what I get talked to a lot is who should we screen and when is it diagnosis versus screening? And the simple answer is, if they're symptomatic, you're going down a diagnostic pathway. And if they're not symptomatic, you're screening. And honestly, the line is so gray, it's incredible, because how you ask someone, are you short of breath? They'll say no. Can you walk up the stairs? No, I can't. Can you walk 3 blocks? No, I can't. The amount of sedentary activity, deconditioning, and particularly in patients with, rheumatic diseases. So I think just assessing, the symptoms is really hard, not even talking about cough and sputum and chest pain. And sometimes we'll find patients who clearly have ILD, great extent of UIP, and we look at their questionnaire and they say not symptomatic. When I call them up, tell them about the results, talk about a treatment plan, they suddenly become symptomatic. So I do think that it's a really tough, it's really tough to really tease out what's really going on with patients.
Well, Janet, anyone take another part of that pie? What do you think?
Right. So delay in diagnosis. So, okay, I think in scleroderma, it's super important to screen, and we do because it's anywhere from as low as 25% to as high as over 50% of our patients with systemic sclerosis will have ILD. About half of those, it'll be relevant that it'll probably kill them. So it's not everybody with ILD is going to progress enough to do them in, but many will. When it comes to RA, there will be a delay in diagnosis, and often what happens is when you're going to start an advanced therapy, you do a chest x-ray, because for all advanced therapies, minus other than rituximab, we're screening for tuberculosis. So often the delay is nobody's listened to the bases of their lungs. And again, if you could spend literally 30 seconds per patient with RA in the room, and I do it with all the SARDs, listen to the bases of the lungs bilaterally every visit, you are going to pick up crackles, and you're going to get really good at picking up the fine as well. The coarse are really obvious, but if you don't listen, it's harder to know. And if I go and do an HRCT on every single patient, I'll get a diagnosis group, I'll get an overdiagnosis, so false positives. I'm going to get pesky nodules that you have to follow, like with 15 other low res regular CTs, etc. So I'm not sure that in rheumatoid arthritis, if I am going to try to treat to a target to remission, and if they don't have high and rich risk factors, older age, men, strongly positive RF, smokers, poor disease control and damage, all those things, if they don't have that, I might delay in the diagnosis if there's a 32-year-old woman, because I am going to listen to her bases, but I'm not doing an HRCT on her. I'm just not. Now, someone can someday show me the data that I'm wrong, but in RA, it's truly 8% in the Rochester incident group. It's 8% in many groups of clinically relevant ILD. There's more ILD than that. And Jeff's group is actually screening a bunch of RA patients to help teach us something about this, but I don't want to make a diagnosis of something they read about that could be a lethal complication if it's a misdiagnosis. So, but delay in diagnosis, you don't want to pick them up either when they're so short of breath that they now have hypoxia, they're aspirating, that we haven't addressed any of it, and they have pulmonary hypertension.
Okay. Elena, comment?
Yes, so I really wanted to emphasize about the applying guideline recommendations to patients. I think it is a great challenge for rheumatology. And in the ACR chest guidelines, I mean, we just, as Jeff mentioned, we just didn't have the data to really give strong recommendations. And we had the most data on some of the oldest drugs, right? Azathioprine and mycophenolate, and they're not really the medications that we as often reach for anymore, especially azathioprine. So I completely empathize that it is very confusing. We did not have a lot of data to provide really clear recommendations. The EULAR recommendations have the benefit of having some more studies that came out after those ACR chest guidelines came out, but even they are not very strong in many cases, but they do include more drugs. So really, I don't have a great piece of advice for this. I would say keeping up with the literature, remembering that rituximab really has probably some of the strongest data in the most of our SARDs, and waiting, I guess, for the updated recommendations. And another mention of IPAF. IPAF was not mentioned in the guidelines. So I understand where it is very confusing and very difficult to apply the guideline recommendations to them because they're not even mentioned. So we don't know how to treat them. So that's all to say there's a lot of work to be done. And I hope to contribute to clearing this up in the future years.
So Jeff, I want to ask you a question about rituximab, because you kind of alluded to the same point that Elena just did, that there seems to be some stronger data maybe, but we've looked at studies, you and I, at ACR and EULAR, where they looked at cohorts treated with biologic DMARDs who had ILD. We're talking very general here. And it showed no difference between the many different biologic classes, MOAs, TNF inhibitors, abatacept, B-cell depletion. IL-6 might have been in there or not. So it doesn't stand out that way, but in some studies it does stand out. So should rheumatologists be thinking rituximab first, or should they just be thinking be aggressive with the underlying disease as the paramount starting point?
Well, I'll plug that next week, though. Is it next week? There'll be the journal club that will talk about Recital, which is a trial of rituximab versus cyclophosphamide, which I think is pretty strong data. Cut to the chase, it showed no difference in efficacy, but much better tolerability for rituximab. And we think cyclophosphamide works. So to me, that's actually really helpful data that rituximab is helpful in its trial data. The studies you're alluding to, and we actually have one in the works as well that will be presented at ACR, is using a target trial emulation of observational data, really, really, really large data sets, finding every RA patient, finding those who have ILD, and then finding their first biologic and seeing how the prognosis is. The kind of sticking point that I'll self-reflect on, given that we're doing some of these as well, is that you have two organs that are perhaps both active, perhaps only one of them active. And, I think in those kind of data sets, you might choose, a TNF inhibitor for someone with a little bit of ILD, but a lot of RA articular activity, and vice versa. You might choose rituximab with a lot of ILD and just a little or no arthritis. And those kind of data sets really can't distinguish between those scenarios and basically just kind of treats them as equal. So my suspicion is that there's a channeling towards more severe patients being treated with rituximab, perhaps that tempers the those are tough patients and they do okay, you're happy. Vice versa, if you have very mild ILD and a lot of arthritis and you use abatacept, those patients are not going to do very poorly from their lungs, and we know the drug works for their joints. And at the end, that's a wash in those kind of really big data sets that the drugs look equal. But I think if we really had a trial, a dream trial would be to do, really rituximab versus, abatacept or toci, et cetera, to really know exactly what they're doing at baseline and what the extent of ILD is, what their pattern is, and, really understanding what the outcomes are going to be. And we are working towards that as well, as you can imagine.
All right, so the question, this question, I want to spend no more than 60 seconds on who should be treated with combination therapies. I ask this because these patients are really bad. The outcomes are really bad. We wait until they're really bad, and then we start treating them with one drug or whatever. And the all of you answered about half that patients with severe or progressive disease should get combination. And combination means either combination immunosuppressives or an immunosuppressive with an anti-fibrotic is kind of what I'm going for here. 20% want pulmonary guidance, 20% want, say, those who fail monotherapy. I need a forward answer from each of you as to whether this is right or whether we should just stick to the guidelines. Jeff, you go
I have
first.
I have a 4-letter answer, MDA5. Those patients I would treat with combination immune suppressant. They're rapidly progressive. It's very lethal in a short amount of time. So those I really give them the full court press. I think all the rest of them are conditional. There might be a few cases here and there I might try a combination, but the ones that aren't quite as rapid, I might do sequential therapy instead of combination.
Janet, what would the guidelines say about this answer?
The guidelines would give that very low level evidence, but that's because there is evidence. So the Nintedanib trial, both census and scleroderma and InBuild, which was non-IPF patients, including our SARD patients in it. And in the latter trial, the SARD ones, they weren't allowed their background immune suppressants, but for short answer, long answer, in a lot of studies, it's Nintedanib plus. And nerandomilast, there was one that will come out soon that seems well tolerated. They could be on Nintedanib and it, so 2 fibrotics together, anti-fibrotics, but they weren't allowed on immune suppressants that could affect lung. So the short answer is, I think no matter what we do, it might not be with guidelines. There might be some evidence you look to. I think anybody worsening on current therapy, my question is always, do I add or switch? And I think the first drug gave some benefit, like the IS, and I'm going to add the basically the anti-fibrotic, or the next in an active RA patient or an active scleroderma skin as well as lungs. I'm going to add 2 immune suppressants, but it's a data-free zone, some of what I'm telling you.
Elena?
Yeah, I tend to be fairly aggressive, especially with anybody with myositis, antibodies. Most of these patients are coming to me on high doses of prednisone, so whatever combination I choose will usually be will have less side effects and less immunosuppression than those 60 milligrams of prednisone they've been on. Not to say that everybody's kept on those for weeks. There is an EVER-ILD trial that compared rituximab plus MMF versus MMF alone in a variety of ILDs with NSIP pattern, and IPAF was represented there. And patients who got combination therapy actually did better with no increase in severe infections. So this is a very important trial for me. And again, one that emphasizes the use of rituximab and also one that emphasizes combination therapy in ILD.
All right, our last slide, we have 2 minutes left. These are questions that may exist in the minds of many. First is an ILD patient that we see in our clinics, presumably either an IPAF or a SARD, and they have an associated ILD. Should we be evaluating them for lung cancer because of that? Because there are some reports suggesting there may be a link. Anyone want to answer that?
I might answer really fast. So scar carcinoma is very rare. I've seen it in systemic sclerosis under a few times.
Did you say scar? Scar?
Yeah, so on the scar, this long-standing, the idea is the long-standing, whether it's fibrotic NSIP kind of pattern or whatever, you can actually get, because it's abnormal cells, they can, I guess, mutate more, and you get carcinoma. It doesn't happen very often at all. I think it's a real thing and super rare.
What about regular, small cell, non-cell?
I'm gonna say, so these people are sometimes their risk is uncontrolled inflammation, but smoking is a huge risk of all things bad in lungs. However, am I gonna do PET scans on all these people? Not right now. But they're getting CT scans. HRCT is a bit different than a regular CT looking for a little nodule. Jeff?
Yeah, I think if these people, I mean, you worry about them for many reasons, but they are getting serial lung imaging for the most part. I will say in patient that has bona fide ILD, I'm not too worried about radiation risk, and I'm not just monitoring with PFTs. I do think getting an HRCT, about annually makes sense. And if they have speculated features and mass-like, lymph node that's borderline, definitely a low threshold for a repeat CT scan. And these patients might need to be biopsied for lung cancer evaluation just to really make sure. So I think these people are monitored pretty close. So I think that's already on the radar.
Our last question is going to be for Elena. Is any of our patients who have ILD that's severe enough, could they be transplant candidates, or does the autoimmune disease make them a non-candidate?
They should absolutely be referred for lung transplant. Actually, the other Dr. Joerns will be talking about it at some point during this month, but there are actual guidelines from ISHLT, which is the Heart and Lung Transplant Association, that clearly indicates that people with autoimmune ILDs should be transplanted when needed, and it does not necessarily lead to worse outcomes.
I want to thank our panel for a fabulous discussion. I want to thank our sponsor, Boehringer Ingelheim, who has sponsored this month, Room to Breathe, focus on ILD, and specifically this webinar. Next week, as Jeff alluded to, we'll be doing Journal Club and talking about pivotal trials. Our two discussants are going to be pulmonologist Toby Maher and rheumatologist Shervin Asasi. And we're going to have two pivotal trials. I think you're going to like that just as well. That's next week, and our final week's going to be on screening and monitoring. Folks, thank you very much for the time. Great discussion. Good night.